Okay, so PET imaging. These are all the different PET tracers. And all of these are made in a cyclotron except for gallium-68 and rubidium-82. Those are made in a generator. So, just familiarize yourself with all of these and know that it's not going to say DetectNet or Axumin. It's going to be the generic name on your board exam. All right, so we know that PET and SPECT are completely different in how they collect the counts. So SPECT literally means single photon emission computed tomography. So one photon, single photon at a time, comes through and it gets picked up by the gamma camera, whereas PET is two photons that go off in opposite directions and hit opposite detectors. Now, not all positrons are created equal. So here are all the different positrons, and they all have different energies. So when they annihilate, they have the same energy, which is 511 keV, but the energy that's given to the positron itself is going to have a different amount of energy. And that's important because when the positron leaves the nucleus, think of it as like you're sending your kid off to college and you give them some money. So we're sending this positron out into the world and we're giving it some energy. It's going to continue to travel through space until it runs out of energy. Okay, so once it runs out of energy, then the annihilation occurs. Two important things. One, it doesn't travel in a straight line. So it's going to travel in an erratic pattern. And the second important thing is that the distance it travels depends on how much energy it has. So if you're going to compare F18 with rubidium-82, you can see that F18 does not travel as far as rubidium-82 does. Why is this significant? Because the camera thinks this is where the tumor is when this is where the tumor is. So you're introducing error in all different directions when your positron is traveling very far before the annihilation occurs. All right, so when the annihilation happens, it hits opposite detectors, and it has to pass two tests. Do you know what the tests are? Timing and energy. All right, so it has to hit the opposite detectors at the same time, and it has to be within the right energy range. All right, so two sources of error that we need to know about. First one is that positron range that we were talking about. So the further it travels, the more error that's going to be introduced into your image. That's the first source of error. The second source of error is something called acollinearity or non-collinearity. So what that means is when these two 511 keV photons are created, and they're created because the mass of the electrons turn into energy, when they are created, they're supposed to go off exactly 180 degrees apart, but they don't. Sometimes it can be off by as much as 0.25 degrees. And the reason that happens is that beta positive particle travels till it runs out of energy. Sometimes it has just a little bit of energy left over, which causes it to change its angle. So that's the second source of error that we cannot accommodate. Okay, so PET imaging, you have these lines of response. They're going off in all different directions. And where those lines intersect, that's where the dot goes on the screen. That's how we localize where it is. Now, there's three types of coincidences that we need to know. The first one is the one we want. It's called a true coincidence. Goes off in opposite directions, hits opposite detectors, passes the timing test, passes the energy test. The second one, you have annihilation reaction. Photons go off in opposite directions, but this one, it scatters. So these two detectors, they communicate with each other, and so they're picking up this incorrect line of response. Nothing happened across this line of response. Now, since this one scattered, it's coming in at lower energy. And if it's lower energy, it doesn't pass the energy test. It might pass the timing test, but it didn't pass the energy test. So this one, scatter, the computer says, nope, we're not going to count it, and erases it. The third one, this is the only one that has two different annihilation reactions. They go opposite directions. This detector and this detector communicate. They hit at the exact same time, and so they also pass the window, the energy test, because neither one of them scatter. So this line of response is counted, and we call that either false, random, or accidental. It has three names. So we cannot prevent this from happening. The only thing we can do is lower the probability of it happening. And the way we do that is we lower the activity we give to our patient. So it's kind of opposite. With SPECT, more activity means more counts, means more information, means a better image. With PET, if you increase the activity, you increase the probability of these false or randoms, and so you actually degrade your image when you give too much activity. Which takes me to 2D versus 3D. Most PET cameras today are 3D, which means they don't have any septa. The old 2D cameras actually have lead septa. And what happens with a 2D, the collimator actually lowers the number of counts, the number of coincidences, because it has to be captured in that plane, in just two planes. 3D, when you remove the septa, now you have an increased count rate. Increased count rate means you're going to have more false or randoms. So when we moved from 2D to 3D, we had to lower our activity. So especially like cardiac PET, rubidium PET, we used to use 50 millicuries and 50 millicuries for stress and rest. Those were on 2D cameras. When we moved to 3D, now we do about 30 millicuries for stress and rest because of that count rate. The other thing that plays into this is what's called time of flight. So conventional PET, you have two photons go off in opposite directions. They hit opposite detectors. We don't know where on this line of response it actually occurred. So we have to collect a lot more counts in order to localize that event. Well, time of flight basically says, you know, this one hit a little bit earlier than this one, so it probably occurred somewhere along this line. So what happens is with conventional, you end up getting all of this just to recognize the dot goes here. With time of flight, you have this. So you have a lot less bad information. Okay, so all of this stuff out here, that's bad information. And when you collect bad information, then you have to collect more good information to compensate for the bad information. So that ties back into, you can lower your activity. You need fewer counts because your counts are going to be better counts. And if you lower your activity, then you have less false or randoms. So it's kind of a cascading. It's like a trickle-down effect. It affects everything overall. This is what it looks like. Without time of flight, you're seeing a noisy image. So you see a lot of stuff in the background here that goes away with time of flight. Because again, instead of getting this, you're now getting this. All right, the other thing we need to talk about is SUVs, standard uptake values. So a standard uptake value, I have two of them here. I have a big one and a little one. It's like an ROI, but with ROIs, we're asking what happens in this region over time. With the standard uptake value, we're asking what is in this region right now. And all we really want to know is how many counts are in there. And we're going to convert those counts to activity. That's why you do a dose calibrator test with your PET camera to make sure your PET is reading the activity the same as your dose calibrator. So you have to make sure that they're the same. And that's because of SUVs. So what we're going to do is first notice that these two SUVs are different size. I have a big SUV and I have a little SUV. So in the SUV calculation, we have to figure out how many counts are in that ROI, convert it to activity, and correct it for the size of the ROI. And then in the denominator, it's how much activity did we give the patient, corrected for the size of the patient. So the numerator is just how much is in the box, corrected for the size of the box. And the denominator is how much did we give the patient, corrected for the size of the patient. And that tells us basically how much activity is in that box. So the most important thing with SUVs is not what this number is, but it's how this number changes over time, because that lets us know if the patient is responding to therapy. So this number went from 9.8 down to 2.3. All right. Skip that. Okay, so the X-ray tube, just a review of the X-ray tube. So the filament is the cathode. That's where the electrons come from. So the electrons come off of the filament. They hit the target. The target is made of tungsten. It's going to be positively charged. The electrons are going to interact with the tungsten, causing X-rays. And there's two types of X-rays they're going to produce, characteristic X-rays and Bremsstrahlung. So in nuclear medicine, we actually learn about beta negative particles causing Bremsstrahlung. Well, a beta negative particle is the same thing as an electron. Okay, so these electrons are in motion and it comes in, it's going to interact. It's negatively charged. The nucleus is positively charged. So this the electron is going to be attracted to the nucleus, and as it does that, it changes directions. When it changes directions, it slows down. Just like when you're driving in your car, you slam on the brakes, you make that turn, you lose energy, it's given off as an X-ray. Characteristic X-ray is different. The electron comes in, it repels another electron. Electron goes out of the atom. This is of the tungsten. So now another electron falls into its place. The difference in these energy, the binding energy, is given off as a characteristic X-ray. So with bremsstrahlung, we can have a wide range of energies. So if I'm really close to the nucleus when I'm coming in, my angle's going to change more. It's going to be higher energy. Further away, I don't change my angle as much. It's going to be a lower energy X-ray. So I'm going to get a wide range of energies, which is what you're seeing here in your bremsstrahlung peak, a whole wide range. You don't get these X-rays. Those are blocked because the X-ray tube is made of a glass envelope and it blocks the lower X-rays from coming out. These are the two characteristic X-rays, and they come from either the L to the K or the M to the K. That's where they come from. All right. And then, of course, we have Hounsfield units. The Hounsfield units relate everything, the density of the tissue, back to water. So water is 0. Anything that's more dense than water gets a number above 0. Below, like fat and air, is going to be less than 0. So here are some common Hounsfield units. And the reason we use this in PET CT is because we get the Hounsfield unit, we convert that to an attenuation correction factor, and then we correct for the attenuation of the PET. All right, MA and KVP. So KVP is going to be the energy, MA is going to be the number of X-rays. If we want more information, we increase the MA, that's going to increase the patient's dose. If we're imaging something more dense or a larger patient, we're going to increase the energy so that it can penetrate through the patient. All right, so that's all the instrumentation of PET CT. Now let's talk about the actual radiopharmaceuticals. So we're going to do oncology first, and we'll start with F18-FDG. Of course, it is a glucose metabolism. So when we talk about the uptake of FDG, we're talking hypermetabolic or hypometabolic. Perfusion means blood flow. So usually we talk about perfusion like myocardial perfusion, cerebral perfusion, renal perfusion, that's blood flow. But here we're talking about metabolism. And what happens? Glucose moves into the cell, the FDG does the same thing. It undergoes metabolism, and then basically the cell says, no, you're not glucose, and does not let it go any further, and so it gets trapped in the cell. And that's why over time it increases, is because the FDG gets trapped in the cell and does not leave. All right, FDG for oncology, we can do a lot of different things. What was I going to say here? This is the general protocol. You probably know this better than I do. MPO for 46 hours. You want a low glucose level. Actually, the normal is less than 120 is normal, but 120 to 150 or 150 to 200 is about what we do. 10 to 15 millicuries, 60-minute uptake time. Most common skull base to mid-thigh, unless you're doing something like melanoma, then top of the head to the bottom of the feet. All right, a couple things to keep in mind. We give the patient a blanket to reduce the brown fat uptake. Avoid talking to reduce larynx uptake. Diabetics, probably a good idea to put them early in the morning. All right, sodium fluoride. This is not FDG. This is like free F18, just like sodium pertechnate is free tech. This is free F18. This is used for bone imaging. So this is an F18 sodium fluoride bone scan versus an MDP bone scan. Obviously, anything SPECT can do, PET can do better. So it's much better imaging characteristics, but it's also much more expensive. So we don't routinely do sodium fluoride PET unless like there's a technetium shortage. Okay, dose is 5 to 10 millicuries. The big difference between a PET bone scan and a general bone scan is that we can image at 30 to 60 minutes. With a whole body MDP bone scan, we have to image at 3 or 4 hours. Okay, those are just some scans. Okay, fluciclovine, also known as Axumin. Do you guys do any fluciclovines? Okay, so the thing to know about fluciclovine is that you're going to see this pancreas. It's like the only scan that we do where you see pancreas. So if you're shown an image and it has the pancreas, it's fluciclovine. This is also the one where we're going to image immediately. So you inject and you start imaging. So you don't wait. So acquire the pelvis first because it's going to start redistributing. All right. The PSMA agents, it's not going to say PSMA. It's going to say gozetitide and piflufolastat. And again, there's one that's gallium-68. So one is gallium-68 and one is F18. And we compare these two. F18, lower energy, shorter range. Gallium-68, higher energy, higher range. F18 is in a cyclotron. Gallium-68 is in a generator. Also know the half-life of these. All right, so it's for prostate cancer. I've given you the mechanism of localization for all of these so you can study those, as well as the normal biodistribution. Dose is 5 to 10 millicuries. We're going to image at 60 minutes like most of them. And the unique characteristic of these is that you see the eyes and the salivary glands. Okay, so if you see that, it's either piflufolastat or gozetitide, one of the PSMA agents. And there's that as well. All right, then we have dotatate and dotatalk. So these are for the neuroendocrine tumors. So I've listed several types of neuroendocrine tumors there, and these can be combined with lutetium-177 therapy. There's mechanism of localization, biodistribution. You can read through that. So now we have copper-64 and gallium-68. So here's gallium-68 and copper-64. So again, the copper-64 is really close to F18 in terms of how it's produced, how far it travels, what its energy is. It has a really long half-life. Gallium-68, again. So what's the difference between dotatate and dotatalk? Well, both are somatostatin analogs, but dotatate is very specific to somatostatin receptor number 2. Dotatalk has affinity for somatostatin receptor 5. Is that important? No, because neuroendocrine tumors, most of them express both of those. All right, dose is about the same. Uptake time, very similar. PrEP, take away their somatostatin analog. So that's the medication that they're taking is somatostatin. And so that's going to the same receptors as this radiopharmaceutical is. And so you have to take them off of that. There's nothing really unique about the imaging. It goes to the liver, the spleen, and the kidneys. So there's nothing really unique. Now it has replaced octreotide. So indium-111, DTPA, octreotide, that was Octreoscan. We're still doing those. That's still on the board exam. It's for the exact same disease, goes to the same somatostatin receptors, but you can see the imaging characteristics are a lot worse with indium compared to PET. PET is always going to give us a better image. All right. And so this is all 4 of them combined. This is the indium-111 pentatriotide, the gallium-68 dotatalk, the copper-64 dotatate, and then this is the lutetium-177 dotatate SPECT. So lutetium-177 also has a low energy gamma emitter, and so we can actually image the therapy portion. All right, fluoroestradiol. This is the exciting one because this one is for breast cancer. Estrogen receptor positive, so it's going to the estrogen receptors at receptor binding. Uptake 60 minutes. PrEP, make sure they're not taking any estrogen blockers. So unique characteristics here. No brain, hot liver. And you also see, you usually see a hot vein. Okay, so that is what distinguishes it from the others. So that takes us into neurology. Notice F18-FDG is actually neurology, cardiology, and oncology. So let's go through these. So what do we use F18-FDG for neurology? We can do it for dementia. We don't do it very often. Really looking for the seizure foci. So patients with really bad epilepsy, we can find where the location of the brain that's causing the seizures and then ablate that. So our job is to find it. And then the other one is radiation necrosis versus tumor recurrence. So if a patient has undergone radiation therapy, and this is their CT scan, what does that mean? Is it just damage from radiation, or has the tumor come back? We can combine that with FDG. We can fuse it together, and that tells us that this is recurrent tumor because it's highly metabolic. All right, ictal imaging, looking for the seizure foci. If you inject during the seizure, it'll be hot. If you inject in between the seizures, it's going to be cold. All right, these 3, these are for Alzheimer's. Do you do these? No. What kind of PET do you guys do?
For PET-CT,
Hmm.
mostly PSMA, melanoma, NCAP. Yeah,
Okay.
a lot
Okay.
of.
So this one is actually for Alzheimer's disease. So this is just of the brain. It's also receptor binding. These are the three that are currently approved. I've just given you the brand names and who makes them. 30 to 90-minute uptake. And basically, we're just looking to see if we see a lot of activity or not a lot of activity. Um, it's going to what's called the beta amyloid plaque that builds up in the brain. Sometimes you have beta amyloid plaque and you don't have Alzheimer's. So if you get a positive, that doesn't mean you have Alzheimer's. But if you get a negative, it means you don't have Alzheimer's. So that's what we're doing, is we're ruling out. And there's a new medication that treats the beta amyloid plaque. So before they get put on that medication, we have to show that they actually have beta amyloid plaque. We don't have to show they have Alzheimer's. We just have to show they have beta amyloid plaque. All right. For tau sapir is also Alzheimer's, but instead of going to the beta amyloid plaque, it's going to the tau tangles. So it's another characteristic of Alzheimer's. All right. Fluorodopa. Did you say you do these? Fluorodopa? Okay. So this is also for Parkinson's. There's a SPECT one for Parkinson's. What's that one called? Do you remember? Ioflupane. DAT scan. So DAT scan or ioflupane is also for Parkinson's disease. So it's basically the same scan, except one's PET and one's SPECT. Also looking at that caudate and putamen. All right, cardiac PET. With FDG, we can do viability or sarcoid. With rubidium-82 and ammonia, we can do MPI. So let's talk about FDG viability first. So with viability, we want to see every part of the heart that has any kind of blood flow. So what we're going to do is we're going to trick the heart. We're going to basically treat the heart like it's a 2-year-old, and we're going to give it some candy. All right, so we're going to give it some sugar. And then while it's sitting there enjoying its sugar, so while that 2-year-old is enjoying its candy bar, we're going to take it away. And that 2-year-old is going to scream until it gets its sugar back. So we're going to take away the heart sugar by giving it insulin. And so now the heart is only thinking about glucose. So when we inject the FDG, it's going to go to anywhere in the heart that is viable. So we're going to pair it with stress rubidium, rest rubidium. We have a matching defect. We want to know if it's viable. So we do an FDG. If it fills in, it's viable. In this case, it did not. So that tells us this is not viable tissue. Now we can also use FDG for sarcoid. Do you guys do sarcoid? Okay, so this is where it gets really tricky, because FDG for viability, we want it to take up the glucose because we want to see glucose metabolism. FDG for sarcoid, so it's the same radiopharmaceutical, we don't want it to take up the glucose. So we want to see, instead, we want to see inflammation. We want to see inflammation, all right? So what sarcoid is basically the immune system overreacts. It's calling the fire department and saying, I've got a 5-alarm fire, and the fire department gets there and there's no fire. So the macrophages, they come in to fight this problem. They get there, there's nothing happening. They build up and form these lumps, and these lumps are called granulomas. So this is inflammation. And we know that glucose goes to inflammation as well as metabolism. So what we have to do is we have to shut off the heart's ability to take up glucose, which is very tricky and very hard to do. What we do is we put them on a high-fat, low-carb diet for 24 hours. And when we do that, we have to, instead of telling them what not to eat, we tell them what to eat. It's like, you can only eat these things. And then they fast for 12 to 18 hours. Now, the heart is very passive aggressive. So if we take away the glucose and it converts to fatty acid for its fuel, it gets mad and it gets very passive aggressive. So when we introduce glucose again, the only thing that's going to take it up is inflammation. It's not going to go to glucose metabolism, because like, no, I'm not doing the glucose thing. You put me on fatty acids. So The prep is the most important thing. 10 to 15 millicuries FDG, image at 60 minutes, combine it with a SPECT or PET. So the prep is important. We have two different patterns here. We have diffuse and focal. If it's diffuse, where it's throughout the entire heart, and you can see the whole heart here, that means they failed their prep. That's non-diagnostic. But if it's focal uptake, that means that they did not fail the prep, and what you're seeing is sarcoid. So here's the rubidium stress, the rubidium rest. Now we're looking for sarcoid. We have diffuse uptake. They failed their prep. That's non-diagnostic. You can see the entire heart here. You're seeing glucose metabolism. Here we have the stress rubidium, the rest rubidium, and there's the FDG, focal uptake. They even did a whole body and found that the patient had systemic whole body sarcoid. So if there's no uptake at all, that means they're normal and they were well suppressed. No sarcoid, and it's diagnostic. Diffuse uptake means failed their prep, non-diagnostic. Focal uptake, they have sarcoid. Focal uptake on a diffusion or perfusion defect, this is why we pair it with perfusion. That means that's really bad. Okay, so they have scar and they have inflammation where the scar tissue is. All right, last one, cardiac PET tracers. We have rubidium and ammonia. Rubidium is going to be in a generator, 75-second half-life. It's like thallium, so the uptake is really good in the heart, and we don't have a lot of uptake in the liver. Ammonia, very short half-life, but it's made in a cyclotron. So you have to have a cyclotron that's really close to you if you're going to use ammonia. But basically, it's just an MPI scan, just an MPI. Same thing with ammonia. All right. That is PET in 30 minutes. Now we're going to do therapy. Have you done any therapies?
Yeah, I have seen therapy. We do a lot of lutetium whole body sweep, like 7-minute sweep for local infiltration.
Okay, all right. It's for is that for lutetium dotatate or the PSMA?
Both.
For both. Okay, very good. All right, so therapy. The good news about therapy, there's only 6 that you have to know. So everything else, there's a whole lot, but there's only 6 here that you have to know. Most of these slides are just reference slides. So I'm going to go through them. I'm going to hit the highlight, and this should be pretty all-inclusive of what you need to know about all the therapies.
Okay.
So the first one, I-131, I've put in here how they're produced, the half-life, the energies of the beta and the gamma, and how it decays. This is the only oral therapy that we have. Okay, all of the other therapies are injected. For thyroid cancer and hyperthyroidism, I've also given you the mechanism of localization, where it distributes, the highest dose organ, and each one of these are going to have a diagnostic pair. So all 6 of these are considered theranostics. Patient preparation, you want them on a low iodine diet because you want those cells to be hungry for iodine. Discontinue their thyroid hormone because that's going to prevent the thyroid cells, the metastatic cells, from taking it up. Levothyroxine, that's T4. Liothyronine is T3, so they need to come off their thyroid hormones. Pregnancy is an absolute contraindication. And then, of course, hydration is always encouraged. The diagnostic workup is that I-123 whole body scan or an I-123 uptake. It depends. If you're looking at hyperthyroidism, you're going to do an uptake. If you're looking for thyroid cancer, it's the whole body scan. Thyroglobulin. Why do we get a thyroglobulin level in somebody with thyroid cancer?
They want to see what they need to give the TSH, the thyrogen before the I-31 the scan.
Okay, so that would be thyrotropin, TSH. Okay, TSH is thyrotropin. But you're absolutely right. You want to make sure that either their TSH level is up naturally or you're going to give them the thyrogen. Thyroglobulin is the bus that's on in the thyroid that carries and makes the thyroid hormone. So thyroglobulin should only be in the thyroid. If the patient has thyroid cancer that has spread outside of the body, then the thyroglobulin can spill into circulation, and that's what we're looking for. So if their thyroglobulin level goes up, it tells us their thyroid cancer has come back. All right, so here's the recombinant TSH. TSH is also thyrotropin. It's an alternative to removing them from their thyroid hormones. We don't want to remove them from their hormones because it makes them very lethargic and low energy and just very sick. All right, so that's the thyrogen there. Again, it's an oral. This is the dose for hyperthyroidism. It's a range. It's based on the type of hyperthyroidism they have. It's based on what their uptake is, and it's based on how big the thyroid is. If we're just ablating the thyroid remnant, because when they take the thyroid out, there's always going to be a little bit left over because you can't get it all because it's right next to the lingual nerve, which will affect speech. So they leave a little bit in there knowing that nuclear medicine is going to take care of it, 30 to 100 millicuries. And then if they have metastatic disease, 100, 200. I've seen upwards of 300 and 400 millicuries given. Radiation safety is a big deal, not because of the beta negative, but because of the high energy gamma. So I-131 has a high energy gamma with an 8-day half-life. And so these patients are going to be putting off a lot of radiation that they're going to expose people to. So we want to isolate them as much as possible. We want them to sleep alone, do their laundry separate because it's going to come through their saliva, through their sweat, through their urine. It's just going to be there. Avoid pregnancy 6 to 12 months afterwards. Imaging. So once we give them the therapy, then we can wait about 7 days and have them come back and we can take an image to see if the cancer has spread. So this gives us a baseline of what we're dealing with. We can use I-123 or I-131. How do you know this one is I-123 and this one's I-131?
I-131 have the star artifact, and then the I-123 is grainy.
Oh. I just locked up. Okay. All right. So I-131 has the
star
artifact. Okay. What causes that star artifact?
That's the gamma.
Yeah, the high energy gamma. High energy gamma. All right. So the purpose of us taking this image is we want to confirm that we have uptake in that thyroid remnant. We want to look and see if there's any regional lymph nodes. We want to look for any distant metastases, and this gives us a baseline of future treatments. So 6 months later, we'll bring the patient back again. We'll see if the therapy, if it's responded to that therapy, and if not, we're going to give them another walking dose. All right, the next one is lutetium-177 dotatate. That is the Lutathera. So lutetium is also beta negative and gamma, but if you notice, the gamma ray is much lower and it's also low yield, which means that every time a beta negative leaves the nucleus, a gamma ray doesn't leave the nucleus as well. So low yield means it only does that a certain amount of time, a certain percentage of time. So radiation safety for this is going to be a lot different than radiation safety for I-131. Okay, so what do we do this for? Gastroenteropancreatic neuroendocrine tumors. Basically all the neuroendocrine tumors, paraganglioma, pheochromocytoma, neuroblastoma, all the endocrine tumors. Mechanism of localization is receptor binding. How do I know that? Because it binds to the somatostatin receptors. So anytime that there is a receptor that it's going to, if you can name the receptor, then the mechanism of localization is receptor binding. And it's a good idea to probably look at those mechanisms of localization before you take your test and make sure you know them. I have them all on the flashcards. These are the diagnostic pair, dotatate and dotatoc. And again, it's copper and gallium-68. We're going to take them off that octreotide therapy, which, by the way, this octreotide therapy is the exact same thing in indium-111 DTPA pentatreotide. It's the exact same medication. So we're going to verify that they do have somatostatin receptors. So we're going to do that dotatate or dotatoc scan, and we're going to take them off their octreotide 4 weeks for long acting, 24 hours for short acting. So what happens is they usually switch them over to short acting for about 4 weeks, and then they take them off their short acting for 24 hours. That way they're not off their therapy for a long time. Okay, this is what it looks like. Important thing here, amino acids. So this is the only one that we give amino acids. Do you know why we give amino acids?
For renal protection.
Yeah, it's going to protect it's going to protect the kidneys. So the amino acids always end in INE. Okay, INE. That tells you it's an amino acid. We're going to give high doses of amino acids, which prevents the lutetium from basically hanging out in the kidneys. And when we do that, it causes nausea. So we also have to give antiemetics. So we're going to start with the antiemetics. So I should really change this slide so the antiemetics are first. We're going to give the antiemetics first. And then 15 to 30 minutes later, that's when we're going to start the infusion of the amino acids. And we continue that for about 4 hours. Okay, here's the dose. It's 200 millicuries every 8 weeks for 4 cycles. Now, the other lutetium one, the lutetium Pluvicto, it's also 200 millicuries, but it's going to be every 6 weeks for 6 cycles. I don't know why they couldn't just make them the same. It would make everybody happy. Just make them the same, but they're not. All right, so this is not Bremsstrahlung imaging. I've got to fix that. This is actually gamma rays. Okay, so gamma rays, I mean, you can image the Bremsstrahlung, but it's actually the gamma ray that we're imaging. So this is the PET, this is the DOTA-TOC, this is the therapy. So we can image to confirm that it's gone to where it's gone. We're not going to see a nice, pretty picture. It's like, okay, here's where we see it. We can see some uptake here. We see it here. So basically, we're confirming that it's gone there. Radiation safety, again, is going to be a lot easier because it's a low-level gamma. So precautions are pretty much just time and distance. And again, you want them to hydrate and frequent void. Now we're going to follow these patients with 3 things: the CBC, renal function, liver function. CBC, we're always going to follow the CBC because that's what the blood-making system is very sensitive to radiation. So we're looking to see that decrease in white blood cells, hemoglobin, and platelets. If that happens, then we have to do something before we can give them another round of treatment. We're going to look for renal toxicity as well, because again, this can do damage to the kidneys. And we're going to look at liver toxicity because this is a medication and medications can harm the liver. So AST, ALT, and bilirubin. All right, so that takes us to this one, which is Pluvicto, but it won't say Pluvicto and it won't say PSMA. It's going to say Vipivitide tetraxetan. So just make sure that you know that that is Pluvicto. Same characteristics as lutetium dotatate because it's lutetium. Diagnostic pairs, the gozetatide and the piflufolastat. So those are the PSMA agents. Now, what is it indicated for? PSMA positive, so they have to have a scan first. Castration resistant. What does castration resistant mean? All right, so when patients get prostate cancer, they put them on hormone therapy. And hormone therapy doesn't mean we're giving you hormones. It means we're taking your hormones away. And so when we castrate the patient, that means we're taking all their hormones away. The idea is that the hormone's feeding the cancer. So if they're castration resistant, that means the cancer's coming back even though they don't have any hormones that is feeding it. So they have to be castration resistant before we do this therapy. They no longer have to have chemo first. So they can come to us before getting chemo. Mechanism of localization is also receptor binding. The receptors they go to are the PSMA receptors. I've given you the normal biodistribution. That's that lacrimal and salivary glands that we see. So confirm PSMA positivity and then make sure that they have good renal function and their bone marrow. They have good bone marrow function. So here's the diagnostic workup. Again, you see those lacrimal glands, you see the salivary glands, and a lot of cancer. We're going to give them antiemetics. The literature says that we're going to use these cooling packs on the salivary glands, which makes sense to me because it's going to be taken up. But everybody I talk to says they don't do that. So do you guys do that where you are?
I don't think so.
Yeah.
They when they receive the therapy treatment is on a different floor. So when we receive them, they already done and use the bathroom and
Okay.
just do the scan.
Yeah. I don't know why it says that in the literature because everyone I've talked to says they don't. But anyways. All right, here's the dose, 200 millicuries, just like the Lutathera, but every 6 weeks for 6 cycles. Again, this is not brimstrawing, this is gamma. So we can image it as well. And here you see that uptake and you can kind of see faint visualization there. Radiation safety, this is outpatients, the same thing for the dotatate. We're going to use time and distance, separate bathroom, avoid contact with pregnant women and children. Follow-up, xerostomia, what that is, that's dry mouth. And so it is going to go to the salivary gland, so it can cause some damage, causing their saliva secretion to go down. And again, monitor that CBC because it can affect blood counts. All right, radium-223 dichloride. It's not going to say Xofigo. This is our only alpha emitter. What's an alpha particle?
That's yeah. Oh.
Yep. 2 protons and 2 neutrons. So it's a very big particle. It doesn't go very far. So if we can localize it where the cancer is, it can do a lot of damage. All right, it's made in a reactor, has a really long half-life, has 5.7 MeV alpha, so it has a high energy, but it's an alpha particle, so it doesn't go very far. That's the mode of decay. All right, diagnostic pair is TEC-MDP or sodium fluoride. So we have to ensure that they have what's called osteoblastic cancer. What does osteoblastic mean?
In the cell in the bone.
Yeah, it's the building up of the bone. So osteoclastic breaks it down, osteoblastic builds it up. So we have to ensure that we have uptake on MDP or sodium fluoride before we give this. Mechanism of localization I've given to you and all that. Oh, the other thing to know about radium-223 dichloride, because we have 2 agents that are for bone cancer, this one and strontium-89. Radium-223 is non-palliative, which means it does something more than just take away pain. Strontium-89 is only palliative. So what does this do other than take away pain? It actually extends life. So they've done studies to show that there is a benefit. I mean, not a lot. And usually these patients are super, super sick. The reason they get this is because they're on high doses of opioids to control their pain. And the opioids are interfering with them being able to have any kind of life at all. And so these are usually patients that are really far in their disease. And so they do this just to get rid of the pain so they can come off their opioids. And it will extend life a couple months, which is a lot actually. All right, so we're going to do a baseline CBC because we need to make sure that they have enough function making blood cells before we give them something that's going to go basically to the bone and hurt that. Verify osteoblastic lesions. There's the MDP or the sodium fluoride workup. All right, this one, the dosing is kind of hard. 55 kilobecquerels per kilogram IV every 4 weeks, 6 injections. So maybe do a couple calculations on that to make sure that you know that before you go in. Radiation safety, it's an alpha emitter, so minimum radiation safety. As long as you don't get it inside of you, you can be around that patient. So it's universal precautions for a week. Follow-up, CBC, looking to see if those blood counts have gone down. Symptom assessment, this should say ALK-Phos. Basically looking to see if the symptoms are going away, the pain. And then the ALK-Phos, you can take that value, and if it decreases, that means that there has been a therapeutic response. All right, 2 more. Strontium-89 chloride, that's also for bone, but this is what we call a pure beta emitter. So when we say pure beta emitter, that means only beta. When we say it's a beta emitter, that means it's beta and gamma, which it doesn't make a lot of sense, but that's kind of how it goes. So it's a pure beta emitter, no gamma. Look at that half-life, 50 days. High energy, also made in a reactor. This is just palliative bone cancer. Now this one is approved for lung, for breast, for prostate, whereas radium-223 is only approved for prostate. Here again, the exact same diagnostic pairs. Again, check to make sure that their CBC is normal. They're going to continue their pain meds. Diagnostic workup is the same. Dosing, super easy, 4 millicuries. Just give it once. No imaging because it's a pure beta emitter. Since it's pure beta emitter, there's no gamma because, again, with I-131, we're concerned about that gamma. So we don't worry about it. And this is kind of silly because I don't think anybody's thinking about pregnancy if they're getting strontium-89 therapy. All right, they might have additional pain for a week or two because as those beta negative particles are hitting those metastatic sites, it could actually, kind of irritate it. And the follow-up is the same thing as the radium-223 dichloride. All right, we're on our last one, Y90 microspheres. Have you seen any of these?
Yes.
You have. Okay, great. So these are the brand names. Generic name is Y90 microspheres. So it's also made in a reactor. It's also a pure beta emitter, so no gamma emission. High energy, 64-hour half-life. It's for hepatocellular carcinoma, and we're going to inject it intra-arterially. So we're not, but the physician is. And so they're going to go up through the groin. They're going to thread the catheter all the way up to the hepatic artery. Once they get to where the tumor is, that's where they're going to inject the Y90 particles. And these are actual particles. Particles are about 50 microns, so about the same size as the MAA particles. So we're going to use Tech MAA first. Why do we use the Tech MAA?
We can see it in the gamma camera to see what this go to the lungs.
Exactly. Yeah. So we'll inject that Tech MAA first, the exact same place where we're going to inject the Y90. And if it leaks into circulation and is picked up by the venous system, it's going to go to the right side of the heart and then stick into the lungs. So we're going to do that. We're going to check that lung shunt fraction. All right, so this is the weird one, okay? This is the only one where our dose is in grays instead of millicuries. So we want to give the tumor 120 grays of activity. That's the absorbed dose. The package insert says the dose to the lung has to be less than 30 gray. Okay, so you might want to know that number, 30 gray. Now, how they determine the millicuries of the Y90 is they take those grays, they multiply it by the liver mass, and then they divide it by 50, and that converts it to whatever the activity is. So you don't have to know that, okay? That equation you don't have to know, but it's around anywhere between 50 and 200 millicuries total. Know that it's 120 gray, and the millicuries is going to be based on the size of the liver mass, sorry. The package insert also says if the liver lung shunt is less than 10%, then that's fine. If it's between 10 and 20%, then you want to consider dose reduction, reducing this 120 gray, maybe reducing it down to 110. And if it's greater than 20%, then they cannot have the Y90. All right, proton pump inhibitor, that's like an acid reducer. And then antiemetics, steroids as needed can also be given. So this is the diagnostic workup. So before therapy, the Tech MAA injection, we're going to do a fraction. After therapy, now this is brimstalling. So this brimstalling, we can confirm that we do have liver uptake. Do you guys do that imaging afterwards, or do you do it in PET?
In the general clinic.
In the general clinic. Okay, so you're doing brimstalling because it's fascinating, really, because the Y90, it is a beta negative emitter, but it also has a low yield beta positive. And so you can image this in PET, or you can image the brimstalling from the beta negative in SPECT.
They usually come back as an outpatient. I don't know how many days after from the Y90, and just a quick picture, and then to see if it's still in the liver.
Okay, yeah. That makes perfect sense. All right, again, pure beta emitter, so brimstalling, body fluid precaution since it's a pure beta emitter, and follow-up, looking for something called post-embolization syndrome. So even though this is a radiotherapy where we're irradiating the tumor, it's also particles, and so it's embolizing, it's cutting off the blood supply. And so post-embolization syndrome can sometimes cause symptoms. So that's just kind of something that they follow up with. All right. That's the end. What questions do you have for me? You have a couple minutes left.
Yes, about the ART, I just study all your slices. Is it going to cover all, pretty much all of it?
Pretty much all of it. I mean, we went through a lot of information in 8 hours. So, yeah. Now, are you familiar with the content specifications that the ART has?
Oh, yes.
Yeah. So I would go through that as well. And as you go through it, if you have any questions, see if you can find that in my slides. If not, send me an email and I'll see if I can help you with that.
Okay.
Yeah. Now, when do you take your exam?
The 6th.
Oh, the 6th. Okay. Do you want to take another mock board exam with me or not?
Oh, yes, I do.
Okay, I'm going to email you a mock board exam. Okay, I'll do that as soon as we get off here. And this mock board exam, it will be set up so it will give you the results immediately. Okay. Okay. And you did the 2-day review, right?
I did. Yeah, I did the one in the spring and the one in the, oh, wait, no, yeah, in May, and then the one that just passed.
Okay. Okay. And did you do that mock board exam?
Oh, yes, I did.
Okay. Okay. So I need to find another one. It's okay. I have another one. I do. I have another one. So I will get you that. I actually have 3 of them. So I'll get you that one. Like I said, it's set up so it will give you the results right away.
Okay.
And so you'll do physics, you get the results, you can go back and study and so on. And if you have any questions, you can contact me.
Okay. Do you have any tips for the ART?
Well, do you have this calculator?
Yeah, I have to. The teacher told us to buy the other one.
This one?
Yeah, this one.
They're very similar. They are very similar. Okay. In fact, their buttons are almost exactly the same, so it's fine. But this is the one that you're going to get an electronic version on the test. Okay, so they're almost identical, so that's fine.
Okay.
So that would be one thing. The other thing is I always recommend when you take tests to read the question and see if you know the answer first, and then look at your choices.
Yes.
Because the wrong answers are called distractors for a reason. So if you read the distractors before you think about what the answer is, it could distract you away from the right answer. So read the question. I mean, if you have no clue, then of course look at the answers, but read the question, see if you know the answer. You probably do. And then you can look, and then read them and read it, read through it, make sure that you understand what it's actually asking you.
Okay.
Yeah.
Thank you so much.
You're welcome. And send me an email after you take your test. Let me know how you do, okay?
Okay.
All right, I'll send you this mock board now.
Okay, great. Thank you so much.
Great, bye.
Okay, bye.